Hello everyone and welcome to edneurorad.com. This presentation will talk about a head and neck CTA search pattern. CTA of the head and neck obviously covers a lot of anatomy, and you want to really split it into vascular and non-vascular findings, because while the interest is on vascular findings, there are a lot of non-vascular structures that you see on a CTA of the head and neck. Now, as a trainee and until your efficiency and speed becomes good, you should always focus on vascular findings first, because the vascular finding can actually be very time sensitive. So if you see a vascular abnormality like a large vessel arterial occlusion, you want to call your referring clinicians and let them know while you're still going through the rest of the non-vascular findings. You don't want to delay. Now, when your efficiency gets better, as is the case, for instance, for me, I actually start with the non-vascular findings. I get those out of the way, and then I end the study with looking at the vascular findings so that I can, this just helps me pay more attention to both the non-vascular and the vascular findings. But as a trainee, I strongly recommend that you go through vascular findings first, and that's the way I'm going to present here. So for vascular findings, you start at the level of at the lowest level, which is in your thorax, and first thing you want to look for is actually for any PE, so the pulmonary arteries. Here, you just get a little bit of the pulmonary artery here coming up, and it's not very well opacified, but sometimes they go down further, and you can actually see the pulmonary arteries very well. And if you go through the cases on this website, there is at least one case here where there is a pulmonary embolus on one of these CTAs. So keep an eye out for these. Then obviously the first step would be to look at the aorta and the great vessels. So here's the aortic arch, and then the branches that are coming off. First is the innominate, then is the left common carotid artery, and then the left subclavian artery. So you start with the innominate, follow the innominate up until it divides into the common carotid and the subclavian, the right subclavian, and then you follow the right subclavian all the way through. All right. So then you look at the left common carotid artery, at least the beginning part of it, and the origin. Make sure there's no narrowing or atherosclerotic plaque, and there isn't. And then you look at the left subclavian artery. So here, there's no narrowing at its origin. And then you just follow it as far down as you can get. It's very common that you would have a contrast column adjacent to one of these in the subclavian arteries, and just that side is just going to be a little bit suboptimally assessed, but do make your best effort to follow these subclavians all the way, because you will sometimes catch unsuspected occlusions. Once I'm done looking at the aortic arch and the great vessels, I focus on the carotid circulation in the neck, one side at a time. So here at the right side, we first start by following your common carotid artery right there. Follow the common carotid artery, comment on any atherosclerotic disease, calcifications, narrowing, etc., until you reach the bulb. The bulb obviously is where the common carotid artery right here separates out into the external carotid artery and the internal carotid artery. The external carotid artery, you can tell it's the external because, it starts to immediately start giving off branches, while the internal carotid artery goes all the way to the petrous canal without any branches. Typically, very occasionally, internal carotid artery will have some of the branches that typically come off the ECA from the ICA, but we don't need to focus on that for the purpose of this basic presentation. Now, you typically in this carotid bulb, that's where you have a lot of atherosclerotic disease and your majority of your stenosis. So you want to give some kind of a degree of assessment of how much stenosis there is here. What people usually expect is like an asset or an asset-like criteria used. That's mild, moderate, or severe. Mild being less than 50% stenosis, moderate being 50 to 70% stenosis, and severe being greater than 70% stenosis. And the way you measure that is you see where it's narrowest at around the bulb. You measure that diameter again. It's all diameter-based measurements. Then you go up to somewhere distal in the ICA where it looks pretty normal in caliber. You measure that diameter, and then based on those two diameters, you calculate a percentage narrowing. So if your narrowest was 2 millimeters and your normal distal was 5 millimeters, that's a 60% narrowing, in other words, moderate stenosis. Now, if your institution relies on you to give exact NASET measurements, so you want to give a number, then that's the way to do it. If you don't really need to give a number, just a qualitative measurement will suffice. You can actually just measure the luminal diameter where it's narrowest. If that number happens to be 1.3 millimeters or lower, that roughly corresponds to severe stenosis. And if that number happens to be 2.2 millimeters or lower, that happens to correspond to moderate stenosis. And that's a relatively good one, and correlates nicely to catheter angiograms even. Sometimes, depending on how this carotid is going, you want to look at it in multiple planes. Sagittal tends to be good. For instance, here, there's a carotid bulb. You can see the internal carotid coming off and the external carotid. Don't forget to utilize your MIPS here. If you put MIP here, you can see nicely how you can see the whole carotid bifurcation right here. So MIPS can be helpful. And then if you have a arbitrary MPR capabilities, you can even rotate this sagittal here so that it's sort of a little bit oblique sagittal, and that would probably even give you a better look at your ICAs. So now for completeness sake, I'll briefly go over the external carotid artery and its branches. In the typical scenario, these CTAs are done for stroke, so the external carotids are not that important. But if they were done for trauma and you were to see weak hematoma and extravasation, you'd want to have some understanding of the anatomy. So you can describe, okay, there's extravasation from this branch of the external carotid artery, etc. Again, in the setting of trauma, you want to look at the soft tissues and see where there's evidence of trauma and look at the external carotid branches there. So there's lots of branches from the external carotid arteries. So we'll go over them sort of inferior to superior. So here's the carotid bifurcation, and here's the external carotid coming off. One of the first branches is the superior thyroidal artery, and this is it right here. This branch, we can trace it down. It comes off really at that under surface of the external carotid artery right after the bifurcation, and it goes inferiorly, and as the name implies, towards the thyroid gland right here. So that's it right there. That's the superficial superior thyroid artery. Then one of the next branches that comes off will be the lingual artery. So we trace this artery here. That's the branch that's coming off, and it goes into the sort of sublingual space. That's the lingual artery. Then one of the next branches will be the facial artery, and that's this artery right here. It sort of goes around the mandible. Right here, that's the branch, facial artery. Then we can try to track out the ascending pharyngeal and occipital artery. So the ascending pharyngeal is actually this guy here. It's pretty diminutive artery right here, that little brightness over there, and you can see it now tracing up towards the pharynx. So that's the ascending pharyngeal artery. Then the occipital artery is the other one that's right next to it, right here, this guy. And you trace it more distally, you'll see that it goes around the occipital artery right there. And now the posterior auricular artery, I couldn't really find it here on the right, but on the left I could find it. Again, it's sort of more evident when you come from distal to proximal. So this probably is it right here, the posterior auricular artery. You trace it proximally, tracing it proximally, and then that's the branch right there. And then it eventually reaches right there to the external carotid artery. So that's probably the posterior auricular artery on the left. Again, diminutive vessel, so I didn't really see it on the right. And then finally, the terminal branches of the external carotid artery would be the the maxillary artery, and the superficial temporal artery. So here it is. Here's a terminal aspect of the external carotid artery, splits up into the maxillary artery and the superficial temporal artery. Superficial temporal artery just has the two divisions, the frontal division and the parietal division, and they separate out going their ways. So again, that's a brief overview of the external carotid branching pattern, just in case you have to have a trauma and want to describe where the extravasation or something is coming from. Once I'm done looking at the carotid circulation in the neck, I spend my time looking at the vertebrobasilar circulation. I look at one vertebral artery at a time. So I make it a point to always make a comment about the vertebral artery origins, just because it can be easily missed. There's common sites of atherosclerotic disease. They could be frankly occluded focally at their origin and very commonly missed on our imaging. So I make it a point of talking about the origin specifically, origins from the subclavian artery. Here's the origin on the right from the right subclavian artery, and then here's the origin. If you follow that, it's a little bit hard because of all this streak artifact, but here's that other vertebral artery, the left vertebral artery, and that's the origin from the left subclavian artery. So we focus, we trace out the right vertebral artery here. So the V1 segment of the vertebral artery is a segment from the origin until it enters the foramen transversarium. So here, so those were V1 segment. Now it is the V2 segment. So it's the V2 segment coming up. We're looking for any sort of atherosclerotic narrowing or a dissection, anything like that. Once it exits the foramen transversarium at C2, and here it is, this little segment that's usually horizontal and like a C-shaped, and that's V3 segment. So this is V3 segment of it. Again, because it's horizontal, you want to take your time, look at all of the trajectory of the vessel, and then once it enters the dura right here, see it's entering the dura and now it's in the CSF space, then it becomes the V4 segment. So now this is the V4 segment of the vertebral artery. Now, the major branch of the vertebral artery is the posterior inferior cerebellar artery, and here it is on the right. This is the posterior inferior cerebellar artery, and here it is on the left, the posterior inferior cerebellar arteries. It's very common for one of the vertebral arteries to be much smaller or diminutive in caliber compared to the other one, in which case sometimes it actually just ends as the posterior inferior cerebellar artery. So you'd follow the vertebral artery, you see that it ends kind of like this, and it doesn't go with the other side to join and form the basilar artery. So that's something to know as a common sort of variant anatomy for the vertebral arteries. Again, sometimes these sagittals can also be helpful for looking at the vertebral artery. This is the left vertebral, the right vertebral, as you can see here, going into the foramen transverse area. This is a V2 segment here. Once it enters the foramen transverse area, here it is, exiting that, here it is right here, exiting that C2 foramen transversarium. And so that's the V3 segment, and then it's entering the dural, and now it's the V4 segment. All right, once I'm done looking at the vertebral arteries, obviously they form up, they join together to form the basilar artery. And the basilar artery has a number of branches. The first ones usually will be anterior inferior cerebellar arteries, or AICAs. So here AR is the one on the left. The one on the right here is diminutive, and that's very common. You know, you see one side, it's probably this little flimsy thing here is the AICA on the right. So you can see them again. You can't make much comment about them just because they're so flimsy usually. So whether they are, if they are, you see them, great, but if you don't see them, you can't really say that they're occluded just because they're usually can be pretty flimsy. As you go up, the next paired branches that come off, and these you can almost always see, are the superior cerebellar arteries. Here's the superior cerebellar artery on the left, here's the superior cerebellar artery on the right, and they supply obviously the superior cerebellum. And then the last paired branches that are going to be probably beefy vessels will be your posterior cerebral arteries. Now, the basilar artery also shows up nicely on the sagittal, and in particular, if you do MIP, here you go, here's a MIP, you can see the vertebral arteries coming together, and on the MIP, you can see the whole course of the basilar artery. So if you had a lot of atherosclerotic irregularity, these MIPs will highlight them very nicely. So, you know, always try to look at these sagittal MIPs. Sometimes even coronal MIPs can be pretty good, although sometimes the bone will tend to eat into that. So here, the vertebral arteries coming together, here's the basilar showing up nicely on the coronal MIP. And then here's the end of it. These are the paired superior cerebellar arteries. That's the AICA on the left, and then these are the paired posterior cerebral arteries. Finally, the last part of the posterior circulation would be the paired posterior cerebral arteries. So here they are, one on the left and one on the right. And the posterior cerebral arteries also have named division. So the P1 segment of the posterior cerebral arteries are from the basilar tip to the level where the posterior communicating artery comes in. So here's the P1 segment. This vessel here is a posterior communicating artery. You can see it's a diminutive vessel. It goes all the way to the internal carotid artery and then joins in with the posterior cerebral artery. It doesn't always have to be diminutive like this. Sometimes it's in fact larger than the P1 segment, in which case it will be called a fetal type origin of the PCA when this posterior communicating artery is actually larger than this P1 segment. And obviously sometimes P1 segment can even be completely absent. So that's another variant. Then once you have that, after this point where the posterior communicating artery joins in, it becomes the P2 segment. And it stays a P2 segment throughout this crural cistern. The crural cistern obviously is that CSF space next to the cerebral peduncle, and then also in the ambient cistern, it's still the P2 segment. So here, this is all P2 segment, and then after that, it becomes the P3 and distal segments. So those are kind of the divisions of the posterior cerebral artery. Again, as is the case, MIPS tend to do a good job picking these up, showing the vessels. Here's a coronal MIP showing your PCAs very nicely, especially the P1 and the proximal P2 segments, but also in the axial MIPS, put it here. The axial MIPS also show the posterior cerebral arteries very nicely here. You can see the large portions of it, pretty much almost all the P2 segment you can see on this single slice, single MIP section. So if there was like narrowings, you'll be able to pick it up very nicely on these axial MIPS. Once I'm done looking at the vertebrobasilar circulation, I look at the intracranial portions of the internal carotid arteries. So we've already looked at the cervical portions of the ICA. So when it enters the petrous canal or the skull base, it becomes the petrous segment here. Sometimes there's a little bit of calcification here, but for the most part, the petrous segment is usually okay. This usually after it exits the petrous segment is a short lacerum segment until it becomes the cavernous segment. So it enters the cavernous sinus right here. Cavernous sinus has a couple of branches. Usually can't see them on your on the CTAs. Once it exits the cavernous sinus, it has a short clinoid segment. Again, doesn't have any branches. And then once it gives off the ophthalmic artery, which it probably does somewhere around here, right here, it becomes the ophthalmic segment. So then from the origin of the ophthalmic artery until the origin of the posterior communicating artery, it's the ophthalmic segment. Once the posterior communicating artery comes off, which on this side, I have a very hard time finding a posterior communicating artery. It's probably just not even there, but it will be somewhere around here, surmising from where it was on the other side. So from the other side, so here's the posterior communicating artery somewhere right here. So it probably will be right around here, where it would be, you would come from the ophthalmic segment to the communicating segment. So from the posterior communicating artery to the carotid bifurcation becomes the communicating segment of the ICA. And sort of you look for any stenosis. In the cavernous segment, it's very common to have calcifications, and sometimes the calcifications are so dense that you have a hard time assessing the true lumen and how narrowed it is. When there's so much calcification, you got to be careful. Don't overcall stenosis there, because usually we call a lot of stenosis there, and then they'll do their angiogram, and there's hardly anything. So just be mindful of that. So once I'm done looking at the ICAs, I look at the middle cerebral arteries. Here's the ICA, here's the ICA. Here it is, division into the middle cerebral artery on the right, and then here's the ICA again, a middle cerebral artery, and then dividing into the posterior cerebral artery. So the middle cerebral artery also has segments, numerical segments. The first segment obviously is the M1 segment from its origin until it actually bifurcates into these two major divisions. And those major divisions, typically there's going to be two, sometimes there's three, but the two major division, one there is a superior going division. Here is this one. This one's a superior going division. And then one is an inferior going division. Here it is, the inferior going division. So those will be your, this branching point right here will be the end of M1 segment. Sometimes it's hard on axial just because one is going inferior and one goes superior. So you can rely on your coronal MIPS like I've put up here. If you traced out this MCA, here it is. Here's that division point, the superior division and inferior division. Sometimes from your MCA, there's a little anterior temporal branch that you don't really count that as a division point. So it's really this distal division point that is counted as where the M1 is. Here you can see nicely the carotid ICA coming in, carotid terminus going into MCA and ACAs. Now we're also take a look at the sagittal MIPS, because those can be also very helpful. Here we are, we scroll over to where that division was. Here is that division right here. This is the superior division M2 and the inferior division M2. And you can imagine if there was like a clot right here, you'd see it nicely on this sagittal MIP. So these sagittal MIPS and the coronal MIPS are very helpful for looking for MCAs. Also, even the axial MIPS can be very helpful, as I show you here. Look at it, that's nice. You can see all of the MCA here in one slice on these MIPS. So again, if there was like a thrombus or narrowing or something like that, you'll be able to pick it up nicely. Now where the M2 ends, M2 technically is the parts of the branches that are within the circular sulcus of the insula. The circular sulcus is just that CSF that's right superficial to the insular cortex, separating it from the temporal lobe and the frontal operculum. Typically at that location, it tends to take a kind of a turn. So right around here is usually where that ends. So this kind of segment would be your M2 segment. Again, where exactly M2 and M3 end is not that important, because the evidence for treating M2, even proximal M2, is quite mixed and weak at the time of this presentation. So really just focus on M1 and proximal M2s, and anything else you can say distal M2, proximal M3. That's I think perfectly appropriate. And finally, we look at the anterior cerebral arteries. Here it is, anterior cerebral artery on the left, and then the anterior cerebral artery on the right, at least the first segment of it, is quite small, as you can see here, until it joins up with the other part, the other side. So the anterior cerebral arteries have also named segments. So the very first part is the A1 segment. There can be a lot of variations in the N1 segment, from them being absent to very hypoplastic, as it is the case here on the right, very hypoplastic A1 segment. When the A1s actually join together through an anterior communicating artery, here's the anterior communicating artery right here, where it's joining between the A1 segment on the left and the A1 segment on the right. And then after that anterior communicating artery, we have the A2 segment. And then the A2 segment goes all the way to the genu of the corpus callosum. So you can see here on the sagittal, you can see that's the corpus callosum here. So all the way up to here are the A2 divisions. And then after that, they become A3 segments. So again, you just follow them along. Now, HCAs, because you see them always in cross section on axials, they're actually best assessed on these sagittals, and in particular sagittal MIPS. You can see very nicely the vessel definitions. They kind of overlap. So if you see a problem with one of these, you don't really know which side it is. So you have to then go to your axials and corroborate that, hey, okay, I see a stenosis right here. You go on your axials to that position, see which one of these two narrows, and then you know which side you're dealing with. So this sagittal is very important for looking at the ACAs. And also, a lot of times you can have vasospasms in these ACAs, vasospasm in any of the vessels, and these MIPS really help in you catching these vasospasms if these things are done in the setting of subarachnoid hemorrhage or hemorrhage elsewhere and you're looking for vasospasm. So never discount the value of these MIPS. So I frequently do one last look at common branch points to look for aneurysms and things like that. And obviously, as you're scrolling through and looking at these vessels, if you see an outpouching, it's an aneurysm and you call it. And the more practice you get, you don't have to be specifically looking for it. A lot of them you'll actually just pick them up as you're scrolling. But I still find it helpful to look specifically at the high yield areas for aneurysms. And those high yield areas would be sort of between the superior cerebellar artery and the posterior cerebral artery right here. You can see that those aneurysms typically nicely on the coronals here. You can see there'll be a little outpouching right here, a little outpouching right there. Between these two. Then the basilar tip aneurysm, so it's just will be an extra little bulge right here where it's not supposed to be, again, will show up nicely on your coronals. Basically, any branch point is fair game, so any of this circle of Willis at the point of this posterior communicating artery coming here would be additional sites, but that you can look for. As far as the anterior circulation aneurysms, again, the cavernous sinus, very common, the cavernous segment, very common area for aneurysm. So you just have to learn to look at the cavernous sinus, and you look at it in multiple planes. So here I look at it even on the sagittal, it tends to show up some of those aneurysms nicely in this cavernous segment. After that, you have your ophthalmic artery coming off. So that's another branch point, common location for an aneurysm right around here. And then here, where the posterior communicating artery comes off, you can have aneurysms here from the posterior communicating artery, or just distal to it being the anterior choroidal artery. The anterior choroidal artery is usually very diminutive. I think here it is on the right, this is the anterior choroidal artery. So you can have an aneurysm right here where that anterior choroidal artery comes off. Then it's the carotid terminus. So here it is, the carotid terminus on that side. Again, diminutive A1 segment here. This will be an aneurysm would pop up there. These carotid terminus aneurysms, again, show up nicely on your coronal images. So here it is. Here's the carotid terminus, right? An aneurysm here would show up as an outpouching right here. Then the MCA and its bifurcation here, right here, would be an aneurysm would show up like this, popping up like that. Again, on axials also, you would see it like right around here as popping up. And then same thing with anterior communicating artery. Again, common location for an aneurysm will be right around here. It will either go up or down. And again, coronals can be pretty helpful for that anterior communicating aneurysm right around here. Again, not an exhaustive list, but these would be common sites. And anytime you see an aneurysm, like make a note of it, make sure that you see what it looks like in all three planes and which plane you think you see it best, and make sure to look when you're looking at that plane in your search pattern, look specifically for that particular aneurysm. Now, the last part of your vascular search pattern should focus on the dural venous sinuses. Again, sort of Fortunately or unfortunately, a lot of time we have venous contamination, and what the venous contamination means is assessing the arteries becomes harder, but you also got to remember to actually look at all the veins that are opacified. This particular CTA, tons of venous opacification, right? So tons of venous contamination. Wasn't the exact best pure CTA that you can imagine, but the nice thing at least is that you get to see those durovenous sinuses, and sometimes people have strokes because of a durovenous sinus thrombosis and not an arterial problem. So you'll be able to catch them. And of course, there's a case of that on this website if you go through the vascular cases. So here it is. Here, so the durovenous sinus anatomy. So you have the superior sagittal sinus. Superior sagittal sinus, it shows up the best on coronals. So let me bring it up into view here. So that's the superior sagittal sinus. You might have to adjust your windows a little bit so to best assess the venous sinuses compared to the arteries. So here's the sort of superior sagittal sinus. On coronal, you can see it in cross section nicely, and sort of you go from anterior to posterior. Here it is. See it pretty nicely. No stenosis, no narrowing, no thrombosis. Sometimes you can see little things like here. Those are almost always arachnoid granulations. If you ever want to know if you're dealing with a filling defect as an arachnoid granulation versus a clot, and you're not quite sure, once you see enough of them, you get a feel for what a clot looks like versus what an arachnoid granulation looks like. But until then, look at your non-contrast head CT. If the location where that filling defect is looks like fluid, that's by definition an arachnoid granulation. Clots are not fluid in their attenuation. If it's fluid, it cannot be a clot. It's an arachnoid granulation. Now, if it's small, you don't necessarily able to tell on the non-con if it's fluid or not. But if it's more sizable, you can on your non-con, especially if you have thin sections, you can on your non-con say whether it's high density or low density. All right, so once you've done looking at your superior sagittal sinus, then it comes down here and then turns into the paired transverse sinuses right here. So transverse sinus on the left, transverse sinus on the right. Again, looking for them for any narrowing, any thrombosis. And then here they are turning into the sigmoid sinus on either side, sigmoid sinus, and then to the internal jugular veins right here. Again, pretty common for one side to be smaller than the other. The way you can tell it's developmental versus sequela of prior thrombosis, you look at the sigmoid fossa here, see how how much indentation the bone has, and also at the jugular foramen. Like if it was developmental and it's small, the jugular foramen has to be small, and if it was not, then the jugular foramen would be normal caliber to the other side. So you can compare the two bony jugular foramina on either side. Other durovenous sinuses, of course, you have here from the torcula, you have your straight sinus right here. And the straight sinus divides into the great cerebral vein, which then divides into the paired internal cerebral veins right here. And then the um, inferior sagittal sinus. Those show up pretty nicely on your sagittals right here. Here it is, straight sinus coming in here, great cerebral vein, and then the paired internal cerebral veins, and then that's the inferior sagittal sinus right there. So those are additional venous structures you can assess. Right, so once you're done with looking at all the vascular, it's time to look at all the non-vascular anatomy you see, and you have the entire head and brain, so you have to look at the entirety of your brain. Now, typically the way these things work, you've already had a non-con head CT as part of the study, so you've already looked at all the head structures. I would argue you should always still look at the brain again on this on the CTA, just because this can really highlight the gray-white matter junction differentiation a lot better, and then strokes would really pop up a lot more. See on this post-con, the gray matter looks even brighter compared to the white matter, so sometimes the infarcts really get highlighted a little bit better on these. So always, make it an effort to look at the brain also on these post-contrast images. Now that being said, something like this on the non-con, this was clearly an area of encephalomalacia or old infarction. On this post-con, it it almost looks like there's cortex here, but that's probably just artifactual But so sometimes it can fool you. So obviously, no substitute for looking at it on a non-con head CT. But if you see something here that catches your eye, you can go back to the non-con head CT and sort of corroborate it or see if you buy it or not. Right. While we already probably had a non-con head CT as part of the study, we probably didn't have anything of the neck. So you have to do a neck soft tissue search pattern, and you have to rely on your neck soft tissue search pattern. We'll have another lecture on this site for a neck CT search pattern. But briefly, sort of what I look for, I'll start looking at the salivary gland. So I look at the parotid glands, parotid gland here on the left, right here, all that tissue, and then the parotid gland on the right. Then I go down and look at the rest of them. So the submandibular glands right here, submandibular gland on the left, right there, and then submandibular gland on the right. And then I look at my pharynx, or the parts that I can see. So here's the nasopharynx, looking for any masses, may see asymmetry, something asymmetrically effaced. My oropharynx right here. And then once that's done, the hypopharynx here. Your piriform sinuses right here. So you see, look for any asymmetric effacement and things like that. The piriform sinuses right here. Then you look at sort of your thyroid gland, again, right here, looking for nodules are pretty common. You can use ACR guidelines to see which nodule requires follow-up, which one doesn't. And then finally, you can sort of just scroll up and down, look at all the nodal stations. Again, this is a brief search pattern. We'll have a much more detailed search pattern for the neck later on. But, unfortunately, you have to sort of include all of the stuff you look for in the neck here. Once you're done looking at the neck soft tissues, you put your lung windows on and just look at the lung apices that you have. I usually just look at the anterior on each side. So anterior lung on the right, scroll all the way to the top. Then I look at the anterior lung on the posterior lung on the right, and then sort of go on with the other side. After that, you put on your bone windows and look at the bones. So you look at the axials, look for any suspicious osseous lesions. I usually don't go crazy if there's a lot of degenerative change, going level by level. That's just way too excessive. Just unless something's really striking at really catching my eye, I just say multi-level degenerative change or something like that. So here it is. And then always make a point of looking at bones on the sagittal, because, a lot of it's pretty easy to get these CTAs. Somebody's found down and they say, oh, found down. Maybe they have a stroke. They get a CTA. CTA part's negative, but they have like unstable cervical spine fracture, and that's why they're found down. So make sure to look at the sagittals here. So you can see a sagittals, make sure there's no alignment normal. There's no bad listhesis. Nothing's fractured. Just because, the fractures a lot of times in the cervical spine show up pretty nicely on the sagittals. And then make sure to look at your craniocervical junction as well.